go ahead and get started. So my name is Barry Sarvet, and I'm a child psychiatrist, and I'm the medical director for the Massachusetts Child Psychiatry Access Program, and I'm really pleased to welcome everyone to our clinical conversations session to kick off the academic year. So I want to just clarify that our program is starting up again, and we are going to continue to be offering these sessions for a monthly basis on the fourth Tuesday of the month. And today we're very lucky and fortunate to have a speaker by the name of Dr. Daniel Dickstein, whose topic is Lessons from the Cutting Edge, Advancing What is Known about Non-Suicidal Self-Injury and Suicide in Children and Adolescents. Before we get started, I want to go over a few housekeeping points. First of all, as you may have heard, the session will be recorded and will be available on the MCPAP website at www.mcpap.com. And so feel free to share this with your colleagues or friends anywhere in the world, and we like to spread the content as far and wide as possible. A copy of the PowerPoint slides will be available on the MCPAP website as well, under the Tools and Resources page under PowerPoint presentations. So Dr. Dickstein will be pleased to answer questions throughout the presentation and also at the end. The way to ask questions that we prefer is to use the question box, which is a function on your screen, which should be on the bottom of your window. And if the question is relevant to what Dr. Dickstein is talking about at the time, then I'll try to let him know about that, and he can address it in the context of his presentation. And if not, we will save them for the end and make sure to cover all the questions in this question and answer part of the talk at the end. And if you would be kind enough to fill out a survey at the end of the presentation, you'll get like a pop-up, and we really appreciate your feedback so we can work on providing relevant content for your practice. So about Dr. Dickstein. Dr. Dickstein is formerly Daniel Dickstein, MD, and he's a fellow of the American Academy of Pediatrics. He did his undergraduate medical education at Brown University, where he earned his MD in the School of Medicine, and he is a triple board person. And what a triple board person is that he completed residency in pediatrics, adult psychiatry, and child psychiatry in one of these really fantastic programs. He is board certified in all three of these fields. He's a professor of psychiatry at Harvard Medical School, and he is the director of child and adolescent psychiatry research at McLean Hospital. Dr. Dickstein is also the director of the Pediatric Mood Imaging and Neurodevelopment, otherwise known as the PD Mind program, where his clinical and research interests include suicide, non-suicidal self-injury, mood disorders, and ADHD and disruptive behavior disorders. So we're really excited to hear what Dr. Dickstein has to talk with us about, and I will turn it over to him.
Thanks so much, both for the invitation to speak, to discuss with the attendees some of their thoughts about non-suicidal self-injury and suicide. Basically, I do a lot of research, but I am a clinician. My research kind of fuels my clinical questions, and I'm excited to share some of that with you today as we talk about non-suicidal self-injury and suicide in kids. In terms of disclosures, I've been lucky and worked pretty hard to get lots of grant funding. I don't have funding from any industry per se, and the work that I'm going to be talking about today was funded in large part by the American Foundation for Suicide Prevention and NARSED, the Brain Behavior Research Foundation. It's especially important to talk about this topic of suicide in September during Suicide Awareness Month. My work in the PD Mind program is really to identify brain and behavior mechanisms of child psychiatric disorders in the hope that that could be turned into more accurate and effective ways to diagnose, treat, and ultimately prevent some of these illnesses. We do lots of brain imaging. We have specialized computer tasks to measure cognition or emotion, lots of ways to get at symptoms and also genetics, putting it all together again for a more accurate approach to mental health. The three things we're going to cover today are to talk about the magnitude of the related but distinct problems of youth suicide and non-suicidal self-injury, NSSI, to talk about some data from a study of teens engaged in NSSI or suicide, but not both, and then to talk about what can be done to address youth suicide and non-suicidal self-injury now, as well as how can better understanding of these brain mechanisms lead to better care in the future. So to start with, what's the magnitude of the problems of youth suicide and non-suicidal self-injury? So when in doubt, going to the newspaper. Teenagers and young adults in the United States are being ravaged by a mental health crisis. We're doing nothing about it. As of 2017, statistics show that an alarming number of them are suffering from depression and dying by suicide. In fact, suicide is now the second leading cause of death among young people, surpassed only by accidents. The author, who's also a parent, asked the question, how is it possible so many of our young people are suffering from depression and killing themselves when we know how to treat the illness? If thousands of teens were dying from a new infectious disease, again, this predates COVID, or a heart ailment, there would be a public outcry and a national call to action. This outrage, I think, is important to be aware of because despite lots of awareness and lots of good treatments, we still don't know enough about youth suicide and non-suicidal self-injury. Not enough kids are being helped. So I want to talk about sort of two prototypical children that I've seen many times in my training, both as pediatrician and child psychiatrist, to highlight in some ways what my research career is all about and what we're going to talk about. I also apologize if during this you hear either thunderstorms or rain because I can't manage to filter out Mother Nature. So Jack, a 5-year-old with fatigue, fever, joint pain, and a swollen belly or bruising. Someone says, hey, something's not right with Jack. We should bring him for a doctor's visit or a nurse practitioner visit. On exam, spleen is big, liver is big, Jack is pale. They order a biomarker, a complete blood count, something we've had many times ourselves in our patients, which shows that Jack's white blood cell count is decreased, but he has a large number of blast immature white blood cells. For Jack, this combination of symptoms and a biomarker has led to early, more specific diagnosis and mechanism-targeted treatment and a better prognosis and outcome. So Jack has ALL, and there's nothing good about ALL. There's nothing good about cancer, but by everybody pulling together to do research to make sure that all the Jacks of the world with cancer are part of research study, to make sure that there's funding for research, that there are lots of referrals for research, Jack now has a 95% 5-year survival rate, whereas cancer in the 80s was an absolute death sentence. So in only a generation, we have radically transformed how we diagnose and treat cancer with astounding benefit. But what about another kid who I see all the time? Gabby, an 8-year-old who can be very moody. At times, she can be irritable, angry, and destructive. At times, she can be sad, sullen, and want to die. At times, she can be hyper, silly, and goofy. At 4, Gabby received therapy for anger and for not following directions. At 6, Gabby was treated for anxiety with an SSRI and therapy, but it led to hospitalization because her behavior became out of control. Do we have a test to determine what diagnosis or diagnoses Gabby has, or what treatment she needs, or what her prognosis will be, or what her risk for suicide is today, in 1 week, in 1 month? Does Gabby need to go to the ER for an urgent evaluation, or does Gabby need to be hospitalized for psychiatric reasons right now? We don't have any of these predictors for Gabby. We know a lot about what could be going on with Gabby, but we don't have ways to transform her care. And so what's the result? Well, the result is that suicide has become the second leading cause of death, starting, believe it or not, at age 10, going all the way up through age 34. Note how cancer sort of markedly falls off the map, again, due to the research and clinical people and families and providers getting together, but suicide is the second leading cause of death of our young people. If you look at this from the 70s to now, while there are ups and downs in rates of males above and females below of completed suicide in kids, the reality is that's basically a straight line. It basically hasn't changed, despite learning lots of things. If you look more in the 2000s, there are some data suggesting that especially for kids, both in females on the left and in males on the right, with data from 2000s in dark blue and 2016 in green, there are increases in youth suicide by about 30% since 1999. Also importantly, about 54% of those who died by completed suicide had no known mental health disorder. So one of the things that we use to predict, do you need care, for almost half of the people, there doesn't seem to be, nobody knew at least, did they have a mental health condition. There are some changes over time. So there are more people who are attempting suicide or dying from suicide by suffocation, but some things don't change decade after decade. So firearms are twice as likely to be in the homes of people who complete suicide versus those who attempt suicide. It doesn't seem to matter how you store the guns, even though, again, with a harm reduction model, we try to get guns out of the home. That's best, but if they're stored in the home, how you store it may not really impact that. Alcohol intoxication is quite common among those who use firearms and complete suicide. Males in general are more likely to complete using sort of classic binary gender, but issues of transgender and other things are also being looked at as risk factors. So again, we know a lot, but many of these things unfortunately don't change using traditional ways of thinking about suicide. And it's not just completed suicide that's unfortunately the problem. That's where we start, but it's not really the only problem. It's not what many of us deal with in our offices. The Center for Disease Control does a survey, the Youth Risk Behavior Surveillance Study, every year or so of high school students. What they find is that in the past year among high school students nationally, about 17% seriously thought about killing themselves at least once. About 14% made a suicide plan at least once. At least 7% made a suicide attempt at least once. 2.5% sought medical attention for their suicide attempt. So that's the tip of the iceberg we see. We talk about this 2.5%, but what about the nearly 1 in 5 high schoolers who have seriously thought about suicide at least once? What happens to them? Joe Franklin did a really interesting study. It's very thorough. He looked at 50 years worth of suicide research from before the 80s to the present, trying to figure out if we're not making progress, what are people doing? And what Dr. Franklin showed is if you look decade by decade from before the 80s on the left all the way up to the 2000 teens on the right, essentially most research related to suicide and self-harm looks at 5 things, and they're the same 5 things time period by time period by time period. There are many of the factors I just talked about, things like demographics, so age, sex, internalizing behaviors, problems like anxiety and depression, externalizing behaviors, things like substance use, aggression, bipolar disorder, social factors, things like relationship loss or fighting with parents or loved one, and prior suicide and life-threatening behaviors. Again, an interesting risk factor, because if we have to wait for people to try to kill themselves at least once to think that they might be at increased risk of doing it again, we have a huge problem because people will die in that first attempt. This is like a horse race where the same 5 horses come in win, place, show +2, but they change in slight order. It really highlights the need for the fact that prediction is little better than chance, and there's substantial need for innovative research. So this is another article I think highlights the tragedy of suicide and the problem of suicide. The headline was, a 19-year-old dies by suicide 1 year after surviving the Parkland shooting. So Sydney Aiello was a survivor of the school shooting in Parkland, Florida. She killed herself. She was a 19-year-old senior. when the gunman went on a rampage, killing 17 students. And people saw that Sydney struggled to attend college. She was afraid of being in a classroom. She was often sad, but had never asked for help before she killed herself. So this is a young person who's at substantial risk for suicide, lots of support around them. And yet, despite all that support, despite all that awareness, they still died of suicide. In 2014, the National Institute of Mental Health and the National Council for Suicide Prevention issued a prioritized research agenda for suicide prevention and action plan to save lives. The hope was to reduce suicide attempts and completions by 20% in 5 years and by 40% in 10 years through 7 main things: to identify why people become suicidal, to figure out how we can do better to detect and predict risk, to figure out what interventions or preventions are effective, what services are most effective, what non-healthcare centered preventions work, and what new and existing research is needed to reduce suicidal behavior. Like many plans, plans without substantial funding and other barriers don't necessarily get achieved right away, but lots of people are working on this. And this item 6 is where I spend most of my time trying to figure out innovative research approaches, much like those used for childhood cancer. I got interested in non-suicidal self-injury as a resident to understand why people would do this behavior, and it remains something that interests me. Non-suicidal self-injury is defined as deliberate destruction of one's body without an intent to die. It can be self-cutting, erasing, scratching, or burning. It's often done on arms, thighs, stomach, areas that can be concealed. While some people use the term suicidal gesture, in many ways it's an outdated term because it sort of thinks about, are they trying to provoke your attention or not? And so instead, just talking about the actual behavior without thinking per se about pejorative things is important. It's not clear that there are sex differences. There are no socioeconomic or ethno-racial differences. And it's a growing problem. It may involve 25% of adolescents, more than 25% of adolescents seen in the ER for self-harm, and it seems to be growing from the 90s to the 2000s to the present. And in terms of the relationship between non-suicidal self-injury and suicide, by definition, it's being done without intent to die, yet it's a substantial risk factor for a suicide attempt. So the treatment of resistant depression in adolescents showed that baseline non-suicidal self-injury predicted a future suicide attempt better than a baseline history of a suicide attempt. Further, baseline non-suicidal self-injury predicted a future suicide attempt among teens despite controlling for past suicidality in another study. And a history of non-suicidal self-injury increased by 7-fold the risk for a suicide attempt in a study by Guan and Prinstein among 400 high school students. So it's definitely something that's separate, but it's related and worthy of study. And we don't know nearly enough about NSSI. We know far less about NSSI than actual suicide in youth. So having reviewed the magnitude of the problem, I want to talk about something that a line of research that we started to try to do something about this. So we talked about how they can be the same, people talk about the same risk factors, they may be related. When I started this line of research, I had already done lots of research on bipolar disorder, which I'm happy to talk about this group at another time. But papers wrote very dogmatically about how non-suicidal self-injury and suicide might involve the same mechanisms. They might involve interpersonal stress versus intrapsychic conflict. They might involve emotion generation or recognition. They might involve cold cognition things, so things done without emotion like decision-making, reward, or impulsivity, or emotion regulation as a final common pathway. There are very few studies of pure kids who did NSSI who had never attempted and pure attempters who had never engaged in self-cutting. And almost nobody had looked at actual objective ways of measuring things using specialized computer tests or neuroimaging. So we stepped into this field with a study of kids who had engaged in non-suicidal self-injury, at least 5 instances of cutting or other self-injury, at least one in the past month, had never made a suicide attempt, defined it, had never did anything deliberately to try to end their life. We had another sample of pure attempters, kids who had attempted suicide without prior history of non-suicidal self-injury, and then a group of healthy controls who had no mental health history. We were trying to look at psychopathology and demographics, but we were also using computer tasks to test out some of these theories. What we found, and the sample is one of the largest of pure cutters, pure attempters, pure healthy controls, about 45 per group, twice as many as we were actually funded to do thanks to some generous philanthropy. The major take homes of what we found demographically is that in our samples, the kids who were engaged in self-harm without suicide history were slightly more female. They had an early onset of the suicidal ideation than the kids who actually tried to kill themselves. They had an earlier onset of their self-injurious behavior. So the kids who cut themselves started cutting themselves earlier than the kids who had attempted suicide. Another thing that was interesting is the reasons they did it were slightly different. So with the suicide attempters in blue and the kids who cut themselves in red, there were significantly more kids who had attempted suicide who tried to kill themselves to escape something or others than that as a motivation for the kids who engaged in non-suicidal self-injury. And the kids who cut themselves were cutting themselves more often because of their current emotional state compared to the reasons why the kids attempted suicide. Specialized computer games. So it's not enough just to interview somebody. Again, following the steps of cancer, getting more into mechanism, objective ways of measurement. And so one of the things we did was, how do you get into peer acceptance and rejection besides just questionnaires? One of the ways you can do that is something called the prisoner's dilemma game. In lots of jargon, this simulates social situations using reciprocal economic exchange. It's something drawn from economics. In plain English, players can win or lose money depending on whether they choose to collaborate with another player or not. And this allows us to look at the strategy of how people play, as well as allows us to look at their self-report of stress or other emotions while they're playing. This is what the screen looks like when they play. And if you look at the left, essentially, if you were playing, you'd be in green. Each turn, you could either cooperate or not cooperate, and you would be told you're playing with another kid at another site. Interestingly, 99% of our kids believe they were playing with kids at other sites because they were all playing multiplayer games, and so it wasn't that far of a stretch from what they actually do. So the fictional player each time could either cooperate or not. And so if you look at the matrix, if both you and the fictional player cooperate, you each get $2. If both you and the fictional player don't cooperate, you each get $1. If you choose not to cooperate and the other person cooperates, you get $3 for hosing the other person, and the other person gets $0. And if vice versa, if they choose not to cooperate with you, but you choose to cooperate with them, the other person gets $3 and you get no bucks. And your decisions are revealed as you go to the right. So you make a decision to cooperate, and then you find out in this decision, both people cooperate. The yellow quadrant is highlighted. We actually thought the play would be different. We thought that the kids who had attempted suicide, most of the time it was their first attempt. It was an impulsive attempt, less than an hour between thought of trying to kill themselves and actually doing it. We thought their strategy of play would be much more impulsive compared to the kids who cut themselves, who had been doing this, repeatedly several times. But it was interesting, their pattern of play wasn't different, but their self-reported stress was significantly different. So kids who engaged in non-suicidal self-injury deliberately talked about having almost 3 times the amount of stress as kids who had attempted suicide, and almost twice as much stress as healthy controls. So again, interesting difference in how people responded to the actual play, but not the actual strategy of play. Another thing we did was we looked at implicit unconscious bias. How do you do that? Well, we were collaborating with Matt Knock, who's at Harvard, who does a lot of research, especially in adults with suicide and non-suicidal self-injury. Dr. Knock has done a lot of work with the implicit association task. And what this essentially is asking you to do, in the middle, in the center, there is a word or a picture of something that might be related to suicide or cutting, or it might be related to something else that has nothing to do with that. At the top, you have categories. So on the left picture, there are the words cutting and not cutting, and me and not me. These word pairs switch. So sometimes cutting and me are on the same side, and not cutting and not me. And then they may switch. So cutting and not me may be on the same side and vice versa. The way you can measure unconscious bias is you have a faster reaction time to things you've thought of before. So if you're a kid who engages in non-suicidal self-injury, if you see a picture of cut skin in the middle and you have to categorize that picture and you see the term me and cutting on one side, you're going to be faster to press the left button because you've done cutting before, you've thought about cutting in yourself before, than if you're a kid who's never cut yourself or thought about cutting when the cut skin, me, and cutting are all paired together. Same thing with an overdose, which is a suicide-related word. If you've thought about killing yourself before, when the term overdose, me, and suicide are on the same side, you will respond faster than if you see the word overdose, me, and life, because you're going to slow down and say, wait, that doesn't make sense. Me and overdose makes sense, but life doesn't make sense. So by looking at differential reaction times, you can look at unconscious bias towards certain things. And Dr. Nock has shown that this pattern of reaction time differs based on people's self-harm history, especially in adults. So this is over 7,000 adults. On the top left, you see that adults who have engaged in non-suicidal self-injury in dark versus those who haven't, the ones who engaged in dark have a less negative or stronger bias towards both self-injury, suicide, and death. If you look on the top right, people who've attempted suicide also have a stronger bias towards self-injury, death, and suicide. So lots of interesting research in adults with this task. Our study was one of the first to look at pure cutters, pure attempters, and healthy controls. And what you see, again, is a stronger bias among the kids who cut themselves towards escape, a stronger bias, not surprisingly, among kids who cut towards cutting. What was very surprising on the right, you see a stronger bias towards death and suicide among the cutters than those kids who had actually attempted suicide. So this was quite surprising to us. I will say the other two things we tested, so cold cognition, impulsivity, decision-making, and reward, that did not show between group differences, and basic aspects of emotion recognition, that did not show differences, which is good because, again, if everything comes up significant, you know you're not pushing your science. So in summary of our first round of studies comparing pure cutters to pure attempters, NSSI is a serious problem associated with earlier onset of self-harm behavior, greater implicit association with cutting and death and suicide, greater self-reported stress during peer acceptance and collaboration and peer rejection. But the two main questions, why haven't these kids who've cut themselves, who have unbelievable access to ways they could try to kill themselves, let alone actually complete suicide, why hadn't they tried to kill themselves yet? What's the mechanism underlying why kids engaged in non-suicidal self-injury? And what mechanism predicts this transition from non-suicidal self-injury as a separate behavior that increases risk for suicide to an actual first onset suicide attempt? Okay, I'm just checking the chat to make sure there are no questions that I need to answer, but happy obviously to answer them. So we've talked about the magnitude of the problem. We've talked about one of our studies of pure cutters and pure attempters. So what can be done now to address youth suicide, and how can better understanding of brain and behavior mechanisms be translated to better care? So many places have a zero suicide plan and project. The idea of this, people talk about, it's like lining up multiple pieces of Swiss cheese, because every plan will have holes, ways people will get through, but the more layers of cheese with holes you have, the fewer people will get through from a suicidal person to an actual completed suicide. And there are multiple layers ranging from screening and assessment to safety planning to treatment to follow-up. This is a study from Pediatrics in 2019, in some ways illustrating one of the problems in these zero suicide plans, especially for kids. Agreement between parents and kids about killing oneself was not so great, was not so high. So most parents, over 50% of parents, were unaware their adolescents had thoughts about killing themselves, and 75% were unaware that their teenagers had recurring thoughts of death. So just parents aren't perfect. Parents are like Swiss cheese. We do our best, but just relying on parents to do this job is insufficient. This is a study looking at universal screening of adults in the ER, essentially asking every patient in the adult emergency department, have you thought about killing yourself? Even if they weren't necessarily there for a mental health condition. What was interesting is just asking that question and then potential related follow-up showed about a 5% absolute reduction in the suicide attempt risk, with a relative risk reduction of 20%. So just asking the question of everybody reduces your holes, reduces the chance that people will fall within the cracks. So how do you ask? Well, lots of people have different tools, and I'd love to hear how people are asking in their own offices or practice. The National Institute of Mental Health developed the Ask Suicide Screening questions to make it easier to ask these hard questions. Again, for many people, it's hard to ask questions about suicide for our own personal reasons or because of what do you do next. But it asks, in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself? Have you ever tried? Have you had thoughts of killing yourself right now? So it makes it pretty straightforward. Again, this is free. It's on NIMH's website. It gives a whole algorithm of what you do based on their score, ranging from praising the patient, if they just talked about, for everybody who talked about it, and then what do you do next about how frequent the thoughts are, or disposition to number 4. But if I call your attention to number 4, so your disposition, what are your options according to this screening tool? You can send them for an emergency psychiatric evaluation. You can decide if there's further need for evaluation by a provider or somewhere else, or they need nothing. And the problem, as we all know, we can't just send everybody to the ER. We can't just admit every patient because we don't have those kind of resources. Even in a fully staffed non-COVID world, we didn't have that, let alone in a COVID world where we have staff shortages and units are closed because of COVID risk and things like that. So what do you see? So over time, more and more kids being hospitalized for suicide ideation or attempt from the mid-2000s to the 2000 teens in both males and females across different ethnicities. This study actually just came out. People ask me, what does COVID do to this stuff? And we can talk, I'd love to hear what you're seeing in COVID times about this stuff and what are you doing? But the Center for Disease Control is looking at emergency department visits. The left actually is adolescents. I apologize. It's left is 12 to 17-year-olds. The right are 18 and 25-year-olds, both in 2019 when COVID wasn't affecting our world through the present. What this overall shows is that in adults, there's not that much change per se for ED visits for suicidality. In kids, there are some changes, but it's not a universal, all of COVID has led to increased ER visits for suicidality. What you're seeing in some ways is lots of stuff in kids is seasonal. And what you're seeing is that at certain times of increased distress, February to March was a particularly rough time as people were starting to, 1 year of COVID and feeling isolated and lots of deaths and other economic impacts of COVID. You're seeing a 50% increase in ER visits for girls and a 3.7% increase for boys. Again, this is as lockdowns are less, COVID impact is higher, but it's not an all or nothing. All COVID is increasing suicide. At certain critical points, it definitely, though, is increasing concerns about suicide. Another interesting study, this literally just came out in Pediatrics from CHOP and their 29 practices over, 300,000 patients, what they actually looked at was the impact of COVID. What they're seeing is that as COVID decreased in-person visits for all primary care providers of kids, there was less screening in primary care for depression. That less screening in primary care for depression was also accompanied by the screens that were being done over time were higher likelihood to be positive for increased depression, especially in females, non-Hispanic Blacks, non-Hispanic whites, and an increase in positive suicide screens, again, especially for female adolescents, up 34% positive suicide screens compared to pre-COVID. The authors conclude that this underscores the need for consistent depression and suicide screening despite COVID, despite restrictions, that primary care providers have a critical role to play, with the hope that consistent regular screening makes sure that people don't fall through the cracks of the Swiss cheese, that depression and suicide don't grow in problem nature so that people actually do things or end up in the ER. This study also talks about things people can do. So safety planning, it's a pragmatic thing that people can do, and would love to hear if people do safety plans or know what safety plans are. But this is from Barbara Stanley, looking at about 1,600 patients, adults in the emergency department, comparing safety planning versus treatment as usual. For those who don't know, a safety plan is a prioritized list of coping strategies and skills. Instead of just asking about suicide and saying, oh, suicide equals admission, or if there's nothing going on, don't do anything. Depending on what's going on in risk, you give them some pragmatic strategies of harm reduction, being in contact with people, trying to sleep regularly, trying to get some exercise, reducing substance use, asking questions about weapons. And what they found was this simple, straightforward, easy intervention resulted in substantially decreased suicidal behavior, with over 45% fewer suicidal behaviors at 6 months of follow-up in those who had had a brief safety planning intervention. Additionally, those who had a safety plan intervention had double the rate of keeping at least one outpatient follow-up. You can do safety plans. So there's an app, again, this is not commercial, this is free. It was developed by the Stanford VA. There's an app called My3. It's on the phone, which is where all of our kids are spending our time, and adults. And it's basically asking somebody to start with, what are your warning signs? What are your coping strategies? What are your distractions? Who's in your network? How do I keep myself safe? What are my reasons to live? It's on the phone, so it's not a piece of paper that won't get used. It can be updated. You add 3 contacts so that with one touch of the button, you call the person to have help super fast. And it also links to 911 and the National Suicide Prevention Lifeline. So something pragmatic that primary care providers can do, quick, easy in the office. Also, what you can do now about cutting, asking and not assuming. Have you ever cut yourself on purpose? When did you do it? Why did you do it? Asking about suicide, which may be a separate problem for many people. Not reflexively sending them to the ER because they may or may not need it. And unfortunately, the reality is we're just not great about predicting who will ultimately need that level of care, who will try to kill themselves in 1 hour or 1 day. Also, not reflexively assuming it's a personality disorder or they're being manipulative. Again, NSSI, we've talked about, is definitely a real problem that has real risk for it. And then can you substitute? So some patients I treat find that some other form of physical sensation is helpful. So filling a bowl of water half with ice, half with water, and putting your hand in it. Most people can't keep your hand in it more than 2 minutes. For some people, that gives them the same kind of sensation without cutting the infection or other issues. What else can you do now? Well, in the PD-Mind program, we're following the example we've talked about childhood leukemia, where better understanding of the biological mechanisms has transformed childhood leukemia from fatal from all to a 5-year survival of 95%. Kids with cancer get married, go to medical school, and have lives. We're seeking to improve our understanding of the brain and behavior mechanisms about suicide, non-suicidal self-injury, and even irritability that could ultimately improve how we diagnose, treat, prevent, and prognosticate these things. We value partnership with clinicians of all backgrounds, families, teachers, schools, community organizations. And we're seeking referrals because the faster we finish these studies, the faster we can translate these into better, more effective ways to diagnose, treat, prevent, and predict. In particular, we have a study of 10 to 17-year-olds who have either tried to cut themselves several times but have not tried to attempt suicide, or healthy controls with no mental health problems. We have another newly funded study for 10 to 14-year-olds who have either made a suicide attempt or are healthy controls. All the families get a research-grade psychiatric evaluation that may help guide care. They get compensated for their time. They get cool brain pictures, and all this information is on our website, pdmind.org. To talk a little bit about these studies, so the NSSI study is a follow-up to the studies I talked about. We're enrolling pure cutters and healthy controls to basically answer two questions. What are the brain and behavior mechanisms that differentiate kids who deliberately cut themselves from healthy kids? And how do those mechanisms predict who will unfortunately make a first attempt at 3, 6, 9, 12, 15, or 18 months versus what kids will not actually make a suicide attempt? Again, this has direct clinical implications and is an important study. And we're about halfway through the numbers we need. But the faster we fill up the study, the faster we have enough power to answer these questions. This other study was just funded by the Hood Foundation, which we're really grateful for the Hood Foundation partnering with us. Long history of funding wonderful pediatric research. This is all about understanding why kids have tried to kill themselves. And again, the follow-up is not as long, but we're trying to understand why some kids will actually make a repeat suicide attempt while others will not. Every referral gets us closer to better care with mechanism-based prediction of cutting and suicide, treatments, ways to retrain the brain for these things, which we've done. We've studied in bipolar disorder, novel and more targeted medications, and better treatments. To explore this just a little bit before I conclude and we have questions. So cognitive remediation is the idea of brain retraining. If you can identify a cognitive or emotional deficit in a patient group, you can design a drill and practice, repeat again and again and again, retraining to build the skill. And then the question is, if you fix the skill, can you also improve the illness? These specialized computer games, which right now are being sold everywhere, but we're talking about ones that actually would be studied to make sure they work, have lots of advantage over traditional therapies. So one is they're scalable. They overcome the traditional one therapist to one patient ratio, because theoretically, if they work and really do affect a specific brain mechanism, you could have thousands, 10,000s of kids all over, not just within big cities, getting quality care, having their brain function monitoring in terms of how they're getting better at a certain skill, and having an objective way to see if that deficit gets better as their clinical illness gets better. People are doing this in schizophrenia, where people have shown that working memory, how you learn and use information, is impaired. People are working on this in anxiety, where people see that attention bias is a problem, meaning you don't just get worried about snakes, all of a sudden you start to see snakes or other feared objects all over the place. And we've done a study, which again, I'm happy to talk about another time, trying to look at this in bipolar kids, where we've shown that bipolar kids with clear manic episodes have impaired cognitive flexibility, or how they adapt to changing rewards and punishments. For the sake of time, I'm not going to talk about that, but people are looking at this a little bit in adults. So I showed you how in adults, people are looking at implicit associations in relationship to self-harm. Joe Franklin, who wrote that 50-year meta-analysis in conjunction with Matt Nock, actually developed a game to try to reduce this implicit bias towards self-harm on a phone-based app. And in a publication that looks at 3 studies of this in adults, they did actually find that this game was able to reduce non-suicidal self-injury, suicidal plans, and suicidal behaviors, but not suicidal ideation. But it wasn't durable, meaning if you stop this game at 1 month, self-harm behaviors went back. So again, understanding the mechanisms in kids could result in better, more targeted treatments. So in summary, NSSI is defined as self-injury without intent to die, suggesting that not all kids who cut themselves need the ER inpatient care, but it does place kids at a 7-fold increased risk of a suicide attempt. It's a growing and serious problem associated with earlier onset of self-harm behavior, greater implicit association with cutting, death, and suicide, greater self-reported stress, during peer collaboration and conflict. There's a critical role for primary care providers to be involved with screening and safety planning, because there's never going to be enough space in the ER or in inpatient mental health facilities to admit everybody who cuts or thinks about suicide. And in the end, answering these key questions of what are the mechanisms underlying why kids cut themselves? What are the mechanisms in that transformation from just cutting to a suicide attempt? And what predicts a suicide attempt, a repeat suicide attempt? These three questions together, we can answer these with our patients and our families and these research studies, that we can make a powerful difference, just like as has been done in childhood cancer, when providers, families, researchers all work together to conduct mechanism-oriented research. We can do a precision medicine approach where we can have better ways to diagnose, treat, predict, and ultimately prevent non-suicidal self-injury and suicide. With that, I really want to thank, we're at McLean now for a year. We're very excited to be part of the McLean and Greater Boston and Massachusetts system. Really grateful to be part of MCPAP. I'm actually doing MCPAP evaluations now, so it's a pleasure to work with lots of pediatricians and other folks. And we've been very lucky to have funders. And with that, I'm going to stop, and I'm happy to take questions.
Thank you so much, Dr. Dickstein. Dr. Dickstein, it was a really nice presentation, and we really appreciate your involvement with MCPAP, both clinically and also in terms of your participating in our program here for the educational piece. I guess I'll kick off the questions. I don't see anything. Actually, there is one question that came in the chat, but I'll go first. I kind of feel like we've given mixed messages to people in this field. By we, I mean the child psychiatry community, and it's related to non-suicidal self-injury. I think we've tried to make the point, that you've made, that non-suicidal self-injury is not the same as suicide attempts, and that it's not necessarily something that represents a life-threatening kind of imminent risk. But you've also pointed out, and I don't think we've made this point well enough, that patients who have non-suicidal self-injury have significantly elevated risks of suicide attempts over the longer term, and so I think that's been misleading to some people, but it's just the way it is. I mean, it's complicated, but I suppose, like, in relation to that misunderstanding, some people are under respond to NSSI and some people over respond to NSSI, and I wonder if you could describe what a reasonable kind of clinical approach should be for a primary care provider when someone presents in their office with on a Friday afternoon, which is classic.
Sure, at 5 p.m.
Exactly. So what should a pediatrician do, and what is the appropriate kind of response?
So it's a great question. Again, I got into this because of my clinical curiosity. I remember when I was a resident, I was in a psychiatry role in evaluating people in the ER. My pediatric co-residents had evaluated a kid who they had medically cleared for psychiatric admission. Kid was in a hospital, Johnny, where it's hard to hide anything. And I had been reading about non-suicidal self-injury. And so I asked, have you ever, having gone through the suicide stuff, I asked, have you ever deliberately cut yourself? And the young woman looked down at the ground. I knew I had discovered something. With some conversation, she basically said she had been cutting herself for several months. I said, where? Because honestly, I saw her arms and I saw her legs at least up to her mid thigh, and my friends had evaluated her. And she said, in her arm. And I said, I see most of your arms. Where? And she pulled up the sliver of a sleeve on her upper arm, and there were 20 plus circumferential cuts, some of which were slightly oozing, again, not gushing, but slightly oozing. That's what got me interested in this. So the 5 o'clock Friday scenario is a common one. I think primary care providers of all types have a hugely important role in screening. That study from CHOP highlights that as people are delaying care because of COVID and other stuff, the screening for depression, for suicide is important. Not being afraid to ask those questions universally, I think, is important. I think giving primary care providers tools, what can you do? Because as they say, don't ask the question you don't want the answer to. You really do want the answer to questions about, are kids cutting? Are they depressed? Are they suicidal? Because there are things you can do, and it's not just sending them to the hospital. So the My3 app gives you plenty of great tools about things to help. It has so many wonderful tools. There's another app called CBTI Coach, which gives lots of tools for depression and anxiety. So there are things you can do, so you don't have to be afraid to ask the question, because asking the question is important. I think substitution in terms of pain for many people is helpful. And again, I've learned this from patients. And I think lastly, what you say about it's this dogma, right? That the dogma got me into this, the dogma about we should or shouldn't care about this. This is or isn't part of borderline personality disorder. That's why I do research personally as a clinician, and I don't have a PhD in research. I did work at the National Institute of Mental Health because of these questions. I wanted to learn about how do you research them. But I think that it's not about the dogma. You have to ask the questions and ask why the kids are doing it. They'll tell you. Some kids are very clear that I'm cutting myself to feel real, to escape, to feel something. That gives you a way to sort of help, then guide some treatment. So I think there's lots you can do by asking. I think asking is a critical role. And I think that's where these studies come in, because figuring out which kids who cut themselves may make a first attempt, we don't know. And so that's why we have that study going, and we really need referrals, because the sooner we can fill up the study, the sooner we can ask the question, the sooner we can have a real evidence-based way to figure out, what do you really need to worry about? What can you do about it? And so that, I guess, is how I'd answer that question, with practical tools for primary care providers, universal screening, and research like we did for childhood cancer.
Thank you so much. So another question.
Go ahead.
No, there are two other questions that are related. So one has to do with whether or not people should feel free to break confidentiality with parents when they learn about NSSI. And then the other question has to do with what is the role of social media in NSSI, and are there any resources to address it?
Okay, so great questions. I appreciate people being courageous to ask questions. So in terms of disclosure, I guess my usual strategy, both I think for my pediatric training and my child psychiatry training is, I honestly work pretty hard to avoid having to keep secrets, because I'm really bad at it. And usually, honestly, that's what I say with patients. I say, listen, I know you're saying you're doing this and your parents may not know, but what is the chance? What's the likelihood they really don't know, or don't know something's going on? Oftentimes there's something that, otherwise they wouldn't be bringing you to the office. They wouldn't, they might have noticed you aren't wearing a bathing suit during the summer at all. So if they have some suspicion, maybe young person, this can be your chance with me and my help to make what's not really a secret really not a secret, so that we can be helpful to you. And most of the time, I will say, the kids and teenagers will take me up on that opportunity. So it's not a forced confession. It's an aligning with them about the fact that this is not really a secret, and how are we helpful. So that's my usual strategy about confidentiality and disclosure related to self-harm, and actually for other things. Would I absolutely, so if they say no way and they clam up and they, I think I would, again, try to focus on aligning with the fact that this is probably not a secret. And again, most of the time they're willing to talk. The issue of social media is asked all the time. Lots of people want me to say that social media is bad. I think the answer is we don't know, right? So right now we have 59 people, I think we're up to 65 people using various forms of intellectual electronic property to connect. So I think the technology is not bad. I think as a parent myself and a provider, being aware of what people are doing with their social media and not just turning a blind eye, I think is important. I think especially looking at how much time people are spending, that is starting to, be seen as a risk factor. The more you spend on social media as a kid or as an adult, the more likely you may be struggling with a mental health thing. And we in our study, actually, our studies are really cool because we have a partner who's a computer scientist So we actually extract social media from the kids in our studies. We instantly anonymize it to protect confidentiality. And so we are actually, with our study, developing objective ways to look at the role of social media and social networking in this complicated NSSI suicide thing, so that hopefully, in a year or two, depending on referrals and completing the study, we could actually develop objective guidelines for what of social media is a risk factor, what of social media is an opportunity to intervene. Does that answer the question?
Absolutely. I think that was a nice answer, Dan. There is another question in the Q&A. I'm not sure if you have thoughts about it or not. I have thoughts about it, but it's from a person who's asking, if a community program uncovers cutting, should they refer the youth, young adult to the pediatrician?
What's your answer?
So my answer, well, I guess it depends, as everything depends always, but I'm assuming that this is a non-mental health community program, that it's a recreational program or some kind of human services type program that's not a specific mental health program. Because if it's a mental health program, then I think that there should be some coordination with the pediatrician, but I think that the mental health program should sort of own sort of the management of that, and the follow-up and the safety planning and all, and the workup, to some extent. But if it's a community program, I think that the pediatrician, as a child psychiatrist, I would say that the pediatrician is a really good first step for alerting the pediatrician and to recommend that the family bring that to the attention of the pediatrician if there's no mental health provider, and then the pediatrician can use MCPAP to try to sort out, what the response is and what the workup should be. But what's your answer, Dr. Dickstein?
Yeah, I think that the question would be, from a community program's perspective, what are their concerns in referring? I think that especially again in the pandemic, community programs, if kids are able to engage in those are hugely supportive. They're great assets for kids and families. And I could imagine sometime there might be a hesitancy about, do I tell? Will that result in the kid not being part of my program? Will they drop out? And so to me, that as we talked about before, building on alliance of the fact the kid is in your program, that you care about the kid, and letting the kid know that you really care about them. It's because you care about them, you want to be helpful, and you'd like to enlarge the circle of who might be involved. And if they have a primary care provider who's part of their team anyway, why not loop them in as a way of being supportive? Again, because you value the kid. And it's probably not a secret, if you've noticed in the community, somebody else has possibly noticed too. And again, I think a lot of times with that kind of joining approach, I think lots of kids are receptive, more receptive than I think we give them credit for.
Yeah, in the spirit of this conversation, that given that we call this program Clinical Conversation because we like to have these sorts of interactions and kind of sort of processing some of these questions together. And I think that you bring up a fantastic point that this kind of discovery is something that has the potential of being highly stigmatized. It can really disrupt relationships, and it's really important that programs respond to these kinds of phenomena with a great deal of sensitivity. There's no one size fits all answer to that question. Really, it depends, and I think that trying to engage with the youth or the child, and to try to involve others, so that it's not just, they're not holding this information themselves, and to try to get the family involved and potentially encourage them to engage with providers that they have a relationship with already, as a bridge, to further kinds of treatment. I think that's sort of one way of thinking that I have as well.
Yeah, I think also, again, so the 1/3 of me that's pediatrician would also say, if you're on a soccer team and you saw one of your star players seemed slower paler, more in pain, you wouldn't keep that a secret. You wouldn't say, gosh, I can't disclose to somebody that they might have symptoms that actually might be medical illness or cancer. I think of it as the same way with emotional pain and mental health issues. We're all there in the end, right? In the community, in schools, families, pediatricians, psychiatrists, psychologists, social workers, nurse practitioners, nurses, educators, for kids' sake. So I guess to me, that's the lens that I guess I would approach these things.
That's great. And that's a great way to conclude. I think we're out of questions and we're out of time. And I just want to once again thank you so much, Dr. Dickstein, for this really great talk. And I want to thank all the audience members who came, and especially those who asked questions. Please, we have questions for you at the end with the survey, so please take a moment to fill it out. And hopefully we will see many of you next month. So thanks so much.
Thanks so much. And again, if I can be helpful to anybody, please feel free to reach out.
Thank you.
Sure.